Welcome to the
Hi,
episode 11 of Vulva Talk. I'm Dr.
11.
Margaret Cox. I'm a dermatologist.
And I'm Dr. Kylie Moss. I'm a gynecologist here in Washington, D.C.
Yes, perfect. Okay, this is the episode 11.
As mentioned. We're
And
going to have a speedier episode
yeah,
today.
it's going to be speedier, mostly because I am live from my bedroom with a newborn. That
Oh
is,
my God. And it's amazing that you are here.
yeah,
Amazing.
trying to fill the time here between naps. And we should start off
Got
this
to do it.
episode with a disclaimer, Kylie.
We are doing this for educational purposes only. This is not medical advice. Talk to your doctor.
Perfect, perfect.
Hey.
Okay, so there's been some interesting vulvovaginal research that has been published just this past month, right? Tell us about it, Kylie.
Yeah. So this is all right. So there was a paper that came out in JAMA Oncology. So Journey of the American Medical Association, their oncology sort of subjournal. And it's open access if you want to check it out. It is a study of a Swedish database. So places that have nationalized medicine, it's always nice because they can follow people for a really long time in terms of their health outcomes. And this was looking at the quadrivalent HPV vaccine. So it has 4 strains that it protects for HPV, and they followed people who got this vaccine. They were born between 85 and 98 and lived in Sweden between '06 and 2022. And they looked to see whether or not they had a diagnosis of high grade vulvar or vaginal dysplasia. And they found that there was a significant reduction in people who had vulvovaginal lesions. So those would be like precancerous changes if they got the vaccine. And that matches what we know about HPV vaccination when we're looking at the cervix and kind of mirrors it. So I thought that this was kind of heartening. How often, Margaret, do you see high grade dysplasia of the vulva, would you say?
Fortunately, I do not see it too often, and I think that's probably because of my
Hmm.
patient population. But when I do see it, I counsel patients that if they have not received their HPV vaccine, it's never too late. That's kind of how I feel. I mean, most of the patients I see are that I'm seeing with high grade dysplasia are kind of 50 and under. If I do see that, I don't know if
Uh-huh.
really recommend it for like older patients. I know when I'm seeing warts in my, like VA male population, I will recommend
Hmm.
HPV vaccination as well. So not only for high grade dysplasia, but for genital warts, verrucous lesions in the genital skin, I'll recommend HPV vaccination as well, and try and work with a patient's primary care provider to get that if they are above 46, which is now the age that it's approved for, correct? I think that's what it is.
Right. I think it's 45 and under. So up to 46, I think. But I would say, I feel like this mirrors what we think about in the cervical dysplasia realm, right? People who have cervix precancer. If they have a LEEP or a cold knife cone, meaning treatment for a really high grade dysplasia to prevent cancer, we know that if we give them the vaccine, they have less risk of having high grade disease or cancer down the line, even if they're already infected. And so I feel like the HPV in the skin, it's causing similar changes in the skin. It's causing sort of unchecked growth of the skin that can lead to a cancer
Mhm.
in the same way it can cause unchecked growth of the cervix. I feel like it probably has some benefit. It's an
Yeah.
immune mediated cancer. These HPV related cancers are related to the immune system. And so if you can buck up the immune system and get them to attack the virus, it makes sense to me. And I've written for, I find if I prescribe it for patients who are above 55,
Yeah.
the pharmacies will dispense it because
They'll
it's
do it.
usually they're going to a commercial pharmacies. Yeah,
Yeah.
Costco, CVS, Walgreens. Yeah.
Yeah.
So I do because I just feel like there's very minimal to lose. I mean, they probably have less immunogenicity, right? Like that's the risk
Right.
with these vaccines down the line is it just won't provoke as much of a response. But we looked at people who were 26 and up in a postpartum vaccine study that I was a part of, and those folks, even with one dose of the vaccine, had a huge response. So I feel like there's very little to lose.
Yeah, yeah, exactly, and I think the adverse effects of that vaccine are so low that I mean, I know I had received mine when it was still the quadrivalent, back in the day. I mean, as a
Yeah.
dermatology resident who's exposed to a lot of HPV in clinic,
Yes.
because we do believe that there's probably some of the cutaneous squamous cell carcinomas that we see, there may be some kind of HPV component. So I'm in there, doing electrocautery on skin lesions and basically vaporizing infection. And if there's HPV just even in adjacent skin that's like normal looking, right? I'm inhaling this and just coming into contact with it. So I received the non-availant one when I started my derm residency because I wanted the extra
Well, yeah,
coverage of
all the
those
strain
additional
coverage.
strains.
And I did the same. I mean, I was like just on the edge of when it was available as a younger person and I missed the window. So then as an attending, I got it in my like late 30s because I was like, I am just inhaling HPV because, it's not
Yeah,
just the vulvar cancers and the cervix cancers, it's head and neck.
head and
These
neck,
throat
totally.
cancers that people get that are HPV associated. Yeah, that
Yeah,
really
and
like
there's like
keep you up at
these
night because those are
yeah.
sneakier and harder to treat.
I mean, there's terrifying stories of like Mohs surgeons in the clinic, and they're doing a lot of these head and neck lesions, and then they end up with like
Yeah,
throat cancer, which is incredibly difficult to treat.
right.
So
Right.
don't
And
want that.
unlike a cervix cancer, which cervix cancer diagnosis devastating, for people who get that diagnosis, but if it is caught early, you can live without a cervix. But when it's your trachea or your, part of your throat, that is a much more challenging thing to ever overcome both surgically and medically, especially if there's widespread disease. I mean, that's true of, cancers anywhere, but I think you get into trouble sooner with a head and neck version. And HBV loves tobacco, so yeah.
I do also counsel
Oh, yeah,
about
go ahead.
quitting smoking, even, with vulvar disease that's HPV driven, smoking is definitely an additional risk factor. What I was going to say is that they were doing a cool study at the VA where we were injecting the HPV vaccine directly into warts to see if that was more beneficial than like systemic or in addition to systemic. I'm not quite sure. I wasn't part of the
Mhm.
study, but that's also kind of like a new
Yeah, yeah.
thing that might be a thing. I don't know if you can do that in the
Oh,
cervix,
yeah,
but
so using yeah, I mean, there are all sorts of, like, immunomodulating things, like, imiquimod, things that people are
yeah.
trying to, like, directly address the lesion, which makes sense. There's also that shiitake mushroom extract that folks can take that have recurrent HPV in it and don't have resolution.
Is that like a oral thing? I think I know that one.
AHCC, active hexose correlated compound, and it's a shiitake mushroom extract. They did a randomized control trial with it, and it enhances natural killer cell activity and does seem to help people who can't clear their HPV of the
Oh,
cervix to clear it.
wow.
It makes sense to me that it would also extend to vulvar cancer in terms of benefits, but it's like concentrated, so don't go chugging shiitake mushrooms. There's like a supplement. But it's not a regulated drug. That's the thing, it's not FDA approved, but there is, one decent paper on it, a small sample size. But the
Hmm.
mechanism is compelling, I think.
Have you had
Yeah.
patients try this?
Yeah. I have. It's been recently because I don't think the paper didn't come out too long ago. And so it's been more in the last year. So I guess I haven't sort of seen the people back and see if they have benefit. But I mean, it seems like a low risk proposition
Yeah.
if it helps.
I'll have to look into that one.
Yeah. Yeah.
This is
It's just one little paper.
good news then, I think, with this HPV trial. And the numbers are
Absolutely.
huge in terms of statistical power, so that's also nice to see.
Yeah, it is. It is huge because these are, rarer outcomes. You got to have a big numbers to actually catch the differences.
Yeah.
All right. Well, you had two, I think, social media
Yeah, I
little
had a
questions,
lot of
right?
little questions
Uh,
coming through, and I feel like these are questions that I always am like, "What's the evidence?" And, there's not a lot of evidence for either of these questions, but there's a lot of recommendations, you know? There's a lot of talk about what is right
Yeah.
and what is wrong. So the first one is about whether you should wear underwear when you go to sleep.
Hmm. Yes.
Mhm.
My answer is wear it or don't wear it according to your comfort. I do not think that it is particularly germane to your vulvar health if you do or do not wear underwear.
Yes, and that is where I stand as well. I think it's a question of personal preference and personal comfort. Although when I did a deeper dive into the research, there were two patient populations that maybe would benefit from not wearing underwear, and that was
I
people
have a
who have
guess.
yeah, so people who have recurrent candidiasis. There's some kind of low level data
Sure.
suggesting that if you have current yeast infections, not wearing underwear might be beneficial because I guess theoretically underwear causes trap moisture, irritation, friction, which can change like the microbiome or the pH or just the general environment of the
And the
vulvovaginal.
fibers. I mean,
Yeah.
the other thing is I think there are fibers in the fabric and the, like, scale of detergent that tends to accumulate on fabric that can harbor yeast and make it very hard to get rid of from the fabric itself. So
Okay.
I could see that.
So that patient population, and then the other patient population, it's kind of grouped into people who have vulvodynia and then like a chronic dermatosis like lichen sclerosis. They may benefit
That's
from
what I was
not
gonna guess,
wearing
yeah.
underwear. And ACOG actually, I was looking, the
Right.
American College of Obstetricians and Gynecologists has this as one of their recommendations, specifically for patients with vulvodynia to avoid wearing underwear at night.
Yeah, yeah. I mean, I think it if you're compressing the area where the pudendal nerves are, I mean, all of those things, make sense to me. And just the friction and the moisture trapping, that all makes sense to me. It's just like we're not going to have a randomized control of underwear versus
No.
no
So
underwear.
yeah.
I
So
don't think anytime soon.
the data that's out there is actually a study that looked at underwear when you're wearing a panty liner. And it was like tight underwear versus loose underwear or like thong underwear versus normal underwear. And they were measuring things like
Yeah.
pH, humidity, and they found really no significant difference. But the trial itself, again, wasn't like someone who was wearing underwear and someone who wasn't wearing any underwear at all. So, really hard to extrapolate.
Right. And liners are a whole different ball game because they can really expose people to chemicals that are um you know, irritating fragrances, chemicals, all kinds of things that are not going to be beneficial to people who are prone to vulvar irritation.
Right, exactly. So I feel like that's kind of a not really a great trial to look to if you're looking for evidence-based advice on this. So I think it really does come down
Right.
to what your preference is. If you fall into any of those two categories, you can try if you wear underwear, you can try not wearing underwear and see how it goes. I mean, I think the other recommendation is to choose underwear that is made from a breathable fabric like cotton and maybe opt for underwear that's like looser and not like really tight and constricting.
And we've discussed our thoughts on thongs here. I feel like,
So
if
yeah,
you have underwear that extends to the perianal skin, the skin around the anus, and then can directly pull towards the vulva, then you're going to get, more exposure to more microbes than maybe is going to be comfortable or healthy. But I don't have a randomized control trial of
yeah.
thong, no thong when it comes to underwear. So that's a low level evidence recommendation.
Yeah, I bring it up too because I did kind of take a look at what reels were out there on, Instagram or what videos were out on TikTok. And there's a lot of people who are blatantly like,
Hmm.
don't ever wear underwear. And I feel like that's kind of like a little extreme. Maybe that's how people get
Yeah.
viral reels because they're like, don't wear underwear. It's like the worst thing you can possibly do. But in reality, it's a lot more nuanced than that.
I feel like 80% of this podcast is us saying depends.
I know.
It
I
depends. It
know.
does. I mean,
It does. It does.
I wish everything was black and white, but almost everything in medicine is nuanced,
Yeah,
and it just isn't straightforward
it's not.
the way that people
It's
want it to
not.
be.
It's
And
not.
if in a TikTok video,
Right, and when I had posted this, my video on this, like, people were like, "Just tell us the answer," and I'm like, obviously it's the answer where I give you no answer."
I know, we don't
Ah,
try. We're not we're not gatekeeping information. There
no.
just isn't evidence to base the
Yes.
recommendation. And so we're saying you have to do what's comfortable for you. I tell people all the time in clinic, like they're like, well, should I do this diet and these, wardrobe changes and this toilet paper? And I say, no, actually, I want to make your vulvar skin tolerate whatever of those choices is comfortable for you and not
Right,
make you have to accommodate your vulvar skin.
right.
So that I think is the goal of good therapy in terms of,
Yeah.
a lot of these conditions.
Totally, and I mean, I think
Yeah.
this also brings me to the next thing that came up recently about again, it's like a
Yes.
personal hygiene thing, and this is about
Yeah.
which direction do you wipe after you go pee, okay? And I feel like there's a lot of
Mhm.
stuff out there saying everyone should be all females, people with vulvas, should be wiping from front to back. That's kind of the thing that is talked about most frequently, and the reason for that is to
Yes.
decrease urinary tract infection is kind of my understanding of this.
Right. If you have, yeah, E. coli lives in the gut. And so if you're having what comes out of your gut come out of your anus, then E. coli, which can cause urinary tract infections, you should go from the front where your urine comes out to the back and not the other way around, right? That's the
Right.
logic.
That's the logic. And I did, again, I went to the evidence. What does the evidence say? There's one paper that was published in like the Acta Obstetrica Gynecologia. And it's a terrible paper,
Hmm.
and I looked at the chart and I was like, I don't understand how this is statistically significant. But anyway, they had found that there was an increased prevalence of urinary tract infection in people who wiped from back to front compared to people who wiped from front to back and compared to people who dab. Okay, so the definitions of this are I'm always
Okay.
kind of but for me
Was
when I
there a
looked
diagram? Like, how
no,
did
there was
people,
a
yeah.
I took a screenshot of it. No, there wasn't a diagram,
Okay.
so I don't know how people were told, to like how this was defined. So I find the design a little challenging and the numbers
Hmm.
didn't really point to statistical significance either. So I don't know if this is like the best paper to to base everything on. In terms of like real life experience, Kylie, what have you noticed?
I've never heard anybody say anything other than front to back, and I've never heard anybody report that they wipe any differently than that. But like if you haven't heard that and you are wiping back to front, is that related to the recommendation and the physiology of that, or is it that you have other circumstances going on that you haven't had a lot of medical education that might make you prone to UTIs in other ways? There's no way to study this question. I think from an anatomy standpoint and from a physiology standpoint, the thing that makes most sense is to wipe front to back. I think that makes sense to me.
Another trial that looked at just UTI risks more broadly, and they had
Mhm.
a lot of different parameters that they were looking at, and one of them was
Mhm.
about wipe directionality. But in this paper, they had grouped front to back was one, and then front to back or back to front was another one. So that was grouped together, which kind of I didn't really understand.
Yeah.
Yeah. And in that one, yeah, their data apparently was statistically significant. Again, it was a little challenging reading the charts, but it seems like a higher risk factor was really if you've had another UTI recently, right? So I feel
Right.
like
Yeah. And that is maybe it is much more to do with your urethral environment and the proteins that you make in your urethra that help cause a mucoid barrier that prevents bacteria from getting into the bladder and a host of other possible factors. But I think absent a trial, which we'll never have, I would recommend front to back.
I was thinking maybe a better solution would just be a bidet.
I was about to say that.
Yes, yes.
Or you could use water and gently cleanse everything.
Yeah. And like I like the idea of a
Yeah.
dab too. I feel like I had read that. I was like, yeah, dab seems,
Yes.
like dab, bidet and
But I
dab.
feel like, yeah, bidet and dab, I think is a good combo. Like rinse and
Yeah.
then pat dry. That's
Yeah, pat
usually what I
dry.
tell people. Bidet
Yeah,
and dab.
yeah,
Yeah, pat. Pat.
bidet and
Just
pat.
nothing aggressive.
Nothing
Bidet
aggressive,
and pat. Yeah.
because I do think, like, the
Nothing
the
aggressive.
the wiping, like, I mean, yeah, can be irritating in and of
Yes,
itself.
I will say you got to be careful with bidets too, because I think I have had people get a little irritated because they were like really blasting the pressure.
Yeah,
And so you want just gentle. Um do not harm your skin by shooting the water to because the jets and different types of bidets, they're not all created equal. And if there's a narrow nozzle, Bernoulli, physics is going to make that water be quite intense in terms of pressure. So it should be gentle because I definitely did have a patient who I think got some irritation from a sort of too aggressive bidet use because water, we talked about this before, like cleansing is good, but you can remove the chemicals that are, sort of protective to your skin with over cleansing.
right.
Yeah. Yeah.
So, the other thing I was thinking about with the front and then maybe I went too deep into, like, Reddit,
Yeah.
which
No,
is the source
let's
of
hear it. Lay it on me.
all knowledge, where there seemed to have been confusion from what I could understand of, like, when you're after you, have a bowel movement versus after urination.
So you're saying if you don't defecate, you wipe in a different direction?
Well, like, that I mean, some people were basically saying, like, I wipe the front and the back differently, so, like, after I poop, I wipe from the back, and then I wipe the front hole from the front. Like,
I mean, I think if you think about the vulva as having a dividing line at the perineum, I guess as long as you keep things separate between the vulva and the anal skin, I guess I don't really care what direction you go in, but I think it's hard not to cross the perineum if you're going back to front. And that's just I recommend front to back, I guess, either way. Because I just think it's very hard. I see people who I'm instructing in application of medication, and it's very challenging. The
yeah,
spatial reasoning, knowing where things are in space is very tricky. So knowing that
yeah,
you're stopping before you get to any skin
yeah.
that's near the vulva,
This
I
is
think would
it's
be
a, yeah.
tricky.
So yeah, I think that the main gist of this is don't put feces in your vulva vagina.
Correct.
Yeah,
And that's a words to live by.
yeah, words to live by.
Yes.
So if you are wiping in
Yes.
a way that you are avoiding that, then you're doing the right thing. It's a debate
So
for
weird.
the ages.
Yeah. I think it's just urinary system and fecal
Yeah,
system should be
should not
separate
should be separate.
when possible. And, if you have risk factors for low estrogen state, help your urethra out by having some estrogen in the area if you're medically able.
Yeah,
There we go. Great.
that's a wrap. Let us know
That's a wrap.
how
Episode 11.
how you wipe. Front to back, back to front, side to side. Just air dry. What do you do?
You can send those to Dr. Cox, actually. And she'll fill me in.
And do you have increased UTIs? I mean,
Yeah.
that's the that's the kind of clincher here. Because if you don't, then does it
Yeah.
matter? I mean, I guess that's the question.
Yeah.
And then,
Oh my gosh.
do you wear underwear? Do you not wear underwear to bed? Does it matter?
Yeah. Yeah. I mean, you don't have to share that with us though. You can just like reflect on that
Reflect on it.
internally. You do what you
Reflect
want with your
internally,
underwear.
and yeah, there you go. I'm Dr. Cox.
I'm Dr. Kylie Moss on Instagram, CHAILEMOSS.
I'm Dr. Cox. What am I? DOCTOR.COCKS. Oh, there's the babe. She made it through.
Yeah. Hi, the baby. She did it.
Did
Well,
it!
thank you
She
for
did
tuning
it!
in despite maternity leave. You are a rock star.
Always a
All
pleasure,
right.
Dr.
We
Moss.
will
Always a pleasure.
yes, absolutely. And we'll catch you in February.
Yep. Awesome. Ciao. Ciao,
Okay.
Bella.
All right.